This is audio lecture part 4 for chapter 6 and 7, reliability and validity in criterion reference tests. In part 3, we talked a lot about criterion referenced evaluations. Now we're going to talk about criterion referenced reliability. So we have both norm referenced and criterion referenced reliability, and they share similar types of reliability and validity. One of the things we had talked about is equivalency reliability and stability reliability. So for equivalency reliability, it consists of two test forms that were designed to measure the same construct. For stability reliability, it's consistency across two trials of the same test, usually taken at different time points. For criterion referenced validity, this is established by confirming some type of test criterion relationship. This is either concurrent or predictive. If we remember, concurrent happens at the same time, and predictive is using data now to predict future achievements. Construct-related validity is demonstrated by examining the overlap of the two divergent groups measured on a continuum. So we're looking at that overlap of that mastery versus non-mastery groups. And we're looking at that continuum. When we're looking at construct-related validity, we're trying to set the cut scores that can be accomplished using the divergent group method with two groups that are clearly different. So, for example, if we have two groups, one that are physically active enough to obtain a health benefit, and the other is not active enough to obtain a health benefit. Those are going to be our two groups. We then want to obtain data for these two groups' physical activity amount, and then we want to graph them. So that's where the distribution for each group is plotted. The point where in the curves where the scores overlap is used as our criterion cut score. So that's the cut score for the minimum amount of physical activity needed for a health benefit. So this is that visual representation of it. On the left, we have those not sufficiently active for a health benefit, and their data is plotted. On the right, we have those sufficiently active enough for the health benefit, and that data is plotted. And then where those two cross is our theoretical cutoff score. This is figure 7.4 in your textbook. We also have another analysis tool. We have the receiver operating curve analysis, or the ROC. This is an example of a construct-related criterion reference test approach. The ROC technique maximizes the number of discriminations between those who achieved the criterion and those who didn't. For example, the NHL, or National Hockey League, created an aggregated performance measure to predict the potential of playing in the NHL. They defined playing as playing at least 5 games within 4 years of being drafted. So that was their overall inclusion criteria. They then set the cutoff at the 80th percentile for defensemen. Then there was a 70% probability that they would play in the NHL, okay? So they took this criteria and measured it, and so the cut score was the 80th percentile for those defensemen. By setting the cut score at the 80th percentile, when they applied that same strategy to forwards, it only led to a 50% probability of playing. So for defensemen, if they hit that threshold, 80 or 70% of them would play in the NHL. But for forwards, that same criteria was applied, and it only led to a 50% probability. So it's important to set those cut scores appropriately for each group. We can apply criterion reference standards to epidemiology in addition to other testing. Epidemiology is the study of how diseases spread and affect populations and how to prevent them. Descriptive epidemiology seeks to describe the frequency and distribution of mortality and morbidity according to time, place, and person. So an example of this would be, what was the rate of breast cancer in adult women in the 1990s? Mortality is death, and morbidity is disease or injury. So the distribution of death or disease or injury. When we're looking at epidemiology, it may help to identify risk factors of mortality and morbidity. And an analytical epidemiology pursues the causes and prevention of mortality and morbidity. So the epidemiology uses research that's both prospective, looking ahead to the future, and retrospective, looking to the past, in order to try to pursue the causes and prevention of death and disease or injury. When we're looking at research designs in epidemiology, they're kind of categorized as two different banks. We have experimental and observational. So in experimental, we have two different types. We have randomized clinical trials and community trials. For randomized clinical trials, that's when participants are randomly assigned to treatments or exposures, and somebody is usually assigned to a control group. So if we think about a medication or drug trial, one group would get the drug and one group would get a placebo. That's a randomized clinical trial. We also have community trials where we randomly assign a whole community to a treatment or exposure, and then another community is our control. So if we think back to the COVID-19 pandemic, a whole community could be assigned to mask, and another community could be assigned, the next town over is assigned to not mask or the control. We also then have our observational studies, and we've got a couple different types of those. We've got a case series, which notes cases at a particular time or place. So it's multiple examples of a specific event with multiple times or places. We've got cross-sectional, which takes a snapshot of identifiable groups at one time. We've got a proportionate mortality and morbidity study, which compares results of a study group to the population. So we're looking at a small group and comparing that to the population overall. We have case control, which compares known cases of mortality and morbidity to matched non-cases. So we're looking to match people that we know have a specific disease to similar peers that do not have a disease. And then we have cohort studies, which are longitudinal and generally track populations long-term. So this could be something like a group being exposed to some sort of environmental pathogen and tracking how they respond to it over time. So when we're looking at statistics and epidemiology, there are some basics. The first is incidence. This is the number, proportion, rate, or percentage of new cases of mortality and morbidity. Incidence can be calculated in a randomized clinical trial or a prospective longitudinal cohort. We also have prevalence. Prevalence is the number, proportion, rate, or percentage of total cases of mortality and morbidity. These can be examined or calculated in cross-sectional studies. So incidence look at new cases, prevalence looks at total cases. When we're analyzing epidemiology studies, we're looking at risk. In epidemiology studies, we're going to convert measures of instances or prevalence into an estimated risk. That's when we get something such as 100 out of 100,000. it allows us to compare two different populations of different sizes when we're talking about estimates of risk. With absolute risk, the risk of mortality or morbidity in a population that is exposed or not exposed to a risk factor. So, are you exposed to that risk factor or not? We also have relative risk, and this is the ratio of risk between the exposed or unexposed populations. And we can calculate with incidence measures. Some additional terms we want to define is odds ratio and attributable risk. Odds ratio is an estimate of relative risk used in prevalence studies, so specifically prevalence studies. We also have attributable risk, and this is the risk of mortality and morbidity directly related to a risk factor, and then the reduction in risk is related to removing a risk factor. So think about smoking, right? The more you smoke, the greater your chance of lung cancer. If you remove smoking, you get a reduction in chances of lung cancer. Let's use an epidemiology example. We're going to talk about cholesterol relative to heart attack, okay? So high cholesterol is defined as a value of greater than or equal to 240 milligrams per deciliter. That's the criterion reference standard for total cholesterol. So if you're 240 and above, you're considered to have high cholesterol. If you're below 240, low cholesterol, because it's criterion referenced, so that's our cutoff score. In this fictional study, we had 56 participants who had high cholesterol and 44 participants with low cholesterol, or cholesterol below the high cholesterol cutoff. So they could have been at 239 to lower, okay? So we wanted to compare these two groups in relation to who had a heart attack and who didn't. All of these participants had a genetic history of early coronary heart disease. So they were considered matched pairs. They all had this common history. So we're going to break it down on the next slide. So we took these fictional people and we put them into this outcome table. So on the left, we can see where we had high cholesterol versus no high cholesterol. And then we looked at, so that's their exposure. Did they have high cholesterol or not? And then did they have a heart attack death or not? So our A group are those that had high cholesterol and had a heart attack death, okay? Our next column over, our B group, are those that had high cholesterol but didn't have a heart attack death. So 25 had high cholesterol and died of a heart attack. 31 had high cholesterol and didn't die of a heart attack. Then we're looking at our other exposure, no high cholesterol. Of those that didn't have high cholesterol, 7 of them still died of a heart attack, but 37 of them had no high cholesterol and didn't die of a heart attack. Based on the data on the previous slide, we can determine or calculate the absolute risk, relative odds, odds ratio, and attributable risk for each component. So if we look in this top, we're looking at our absolute risk. So it's broken up into high and not high. So those with high cholesterol had an absolute risk of 45% of dying from a heart attack. Those in the not high category had only a 16% chance of dying from a heart attack. Then when we're looking at our relative risk was 2.81. Our odds ratio is 4.26. And our attributable risk is 0.64%. So what does all this data mean? The absolute risk for a heart attack death was 32% for all participants. So regardless if they had high cholesterol or not, their risk of dying from a heart attack was 32%, okay? Or 32 out of 100 people would have died from a heart attack. Remember that these people did have a genetic history of coronary artery disease, okay? 45% was the absolute risk for participants with high cholesterol versus only 16% for the participants without high cholesterol. So just because you didn't have high cholesterol didn't necessarily mean you wouldn't die from a heart attack, but your risk was a lot lower, almost more than half. Also, if a participant had high cholesterol, the relative risk of 2.81 indicated that high cholesterol elevated the risk of a heart attack by a multiplier of 2.81. So you were 2.81 times more likely to die of a heart attack if you had high cholesterol. So all that data is great, but what does it mean? So if a participant had high cholesterol, the odds ratio indicated an elevated odds of a heart attack mortality by a multiplier of 4.26. So if they had high cholesterol, they were 4.26 times more likely to die of a heart attack than those that didn't have high cholesterol. The attributable risk indicated that high cholesterol contributed to 64% of the heart attack mortality. So we could reduce heart attack mortality by 64% if high cholesterol was no longer present in the people of this population. So if those people didn't have high cholesterol, their risk or attributable risk of dying from a heart attack would decrease by 64%. I know we've gone over a lot of content over the course of multiple videos, but to summarize all of the videos, reliability, objectivity, and validity are the most important concepts. Reliability and validity results are not typically generalizable. They are for a fixed population or a fixed time, etc. And the results are specific to the group tested, the environment of testing, and the testing procedure. Criterion reference testing is the method of choice when variables are categorized and an obvious level of proficiency must be achieved. So this is definitely the preference, especially when we need that cutoff score to show proficiency or mastery. Criterion reference reliability and validity statistics that we talked about are that chi-square. And then epidemiologic statistics are closely related to criterion reference test procedures and are powerful tools for identifying risk factors for various disease outcomes. The following slides are some review questions for the totality of these chapters. I would highly recommend doing them before you do the module quiz and also review them before your exam.